Yes, sir.
Yeah.
So regarding cardiovascular system, I would say there's not very much not in detail to go about, but I'll try to explain whatever is important for the undergraduates and what you should really focus on during your exams. Most of the things, I mean, frankly speaking, during the day of exam, probably I would say 60-70% of you would know what the case is. So what mistake you generally do is you try to approach the exam, trying to fit your findings into it. Don't do that mistake, because the examiner is not looking at your diagnosis or anything. He's just basically trying to see how you're approaching it. Okay, so don't try to fix your findings knowing the case beforehand. Okay, that will not help you. So basically in cardiovascular system, when you are asking history, you have to know, as usual, what are the chief complaints, and after chief complaints, you will ask what is the onset, duration, progression, aggravating factors, relieving factors. So you have certain cardinal symptoms in cardiovascular system, that is breathlessness, cough, chest pain, palpitations, and of course orthopnea, P&D, all those things comes in breathlessness. So these are main cardinal symptoms, and sometimes hemoptysis you do get. And other associated symptoms you might get, such as nocturnal urination, and then pedal edema, that is swelling of lower limbs, okay, abdominal distension. These are certain associated symptoms which you might get. Very rarely some yellowish discoloration of eye, bluish discoloration in congenital heart disease, all those things will come. So how you put the pieces together, that depends on your examination findings. So suppose, say for example, in your exams, most commonly the cases kept is for short cases, you will get something like clubbing, or some aortic regurgitation, auscultate this patient cardiovascular system and tell your findings. Okay, or you might get proper valvular heart disease in your long case. So this is the most common, and most likely it will be a rheumatic etiology. Very less likely that you will have a cyanotic congenital heart disease or something like that. So basically, if you're looking at aortic stenosis, aortic lesions, you'll have something like giddiness, syncope attacks, okay, or exertional breathlessness. These are the and fatigue. These are the main complaints what you'll see in an aortic valvular disease. If you're looking at a mitral valvular disease, breathlessness, usually orthopnea, P&D, these are the symptoms which come. And then once the right heart starts failing, you get pedal edema, and these are the symptoms what you see with mitral valve. Sometimes, of course, usually for undergraduates, mixed valvular lesions are very, very less likely for you to get in the exam. But yes, in certain places they do keep mixed valvular lesions. All right. And coming to other congenital diseases, something like Marfan syndrome, bicuspid aortic valve, aortic coarctation, all those things are less common in undergraduates, but these are certain things which you have to keep in mind. So with this brief history, we'll go on to examination part. Kishan, can I share my screen? I want to show them.
Please. Yeah. You are a host, so you can share.
All right. So what all you want to look for in case of a general physical examination, in case of a CVS? Anybody can take this question? Anybody?
Avantika, Aishwarya. Anybody can answer. Today's it's gonna be an interactive session, so anyone can mute yourself and try to answer. Okay, please don't hesitate and try to answer. It will really help you.
I'm not seeing your face, so I don't.
Yeah.
I don't think you should hesitate. Just go ahead and tell your answers. Don't worry.
Cyanosis.
Okay.
Clubbing.
Yes.
Edema.
Correct.
General examination.
Yeah. What else? What else in head-to-toe examination? What else you want to look for? Okay, so I'll just share the screen. I'll share certain GP examination pictures. So I'll tell you what is the significance of all these things in general physical examination. All right. Okay. Is it visible, the picture?
Yeah, it's loading, Varun. It will come.
Can anybody tell what is this? less common for undergraduates, but still, I mean, you can find sometimes. What is this scar?
Can you click again on the particular video or image, please?
Yeah. Is it visible?
No, it's still loading, actually. Can you just right click and open that? Try to.
Did that come?
No, no. Okay. Anyway, members, we can zoom the screen for ourselves. Okay, we can zoom it. And
Yeah, if that option is there, we can go ahead and zoom this.
Yeah.
So Shravan here. So when you're sharing the screen, so if you use this share screen option instead of like files or something, so then you will be able to open the video or the picture, sir.
Okay, I did execute that screen sharing first. Then only I opened the photo.
Okay, so because usually then it will be visible if you do it that way. So if you could you just try it once again, sir? Because in YouTube the pictures will not be visible at all, sir.
Okay. Is it coming now?
So it's not coming, sir.
Okay, no issues.
No, can you click on one of the videos, please?
These are pictures basically. Okay.
A picture, please. Can you click on that?
Yeah, is this loading?
No.
No, fine. No issues. I mean,
it's MP4 format. Okay. Just right click it or you can try to open, please.
So you could try one more thing. You could keep the picture open, so and then click on screen share. That will allow you to share only the picture.
Okay.
So that
fine. I'll do
might
that.
also work.
Yeah, is
Yes,
it coming
sir,
now?
visible. Yes, sir.
Okay, fine. So what is this? Any idea? Anyone? No, it's not a valvotomy scar. It is basically a pacemaker. Yes, somebody has answered. It's a pacemaker which is inserted. All right. So in GP, this is one of the things which you have to look for. All right. I just show all the pictures quickly. So okay, is this visible?
Yes, sir, it's visible.
Yeah. So what is the significance of icterus in a cardiovascular system? Anybody?
Congestive hepatomegaly.
Okay, that happens in a very late stage, but I would take that answer. Congestive hepatomegaly is yes. When there's a right heart failure, it will usually take at least 10 to 15 years, for congestive hepatomegaly to go into cirrhosis, and then it can cause cardiac cirrhosis and icterus. Yes. Any other cause?
You already answered there in the chat section.
Okay.
Infective endocarditis.
Correct. Infective endocarditis. Anything else? Mechanical valves is another.
Yeah. Prosthetic. They answered. Varun. Prosthetic valves and the hemorrhage.
Okay. Okay. What is this? Anybody?
Marfan syndrome.
Correct, Marfan syndromes. So you have to expect certain cardiac anomalies such as bicuspid aortic valve, okay, aortic aneurysms, okay, and coarctation of aorta. These are all possible cardiac lesions, what you can expect in patients with Marfan syndrome, okay. Okay, is this picture coming?
No. Yes, sir. It's loading.
Xanthelasma.
Xanthelasma.
Correct, xanthelasma, good. Okay, what is this?
Frank sign.
Frank sign. What is the significance of Frank sign?
It indicates atherosclerotic changes.
Okay, usually it will indicate triple vessel disease in patients with cardiovascular problems, right? Okay, this one.
Sphincter hemorrhage, infective
Correct,
endocarditis.
splinter hemorrhages. So when do you say splinter hemorrhages are abnormal? You know, sometimes there can be trauma and you might have some amount of splinter hemorrhages, correct? So when you say, you know, certain amount of splinter hemorrhages are abnormal, any particular number is there? Anyone? Okay, usually if it is more than 2, it is considered as pathological, okay? Fine, this thing, anybody? Of course, this is very difficult to see in Indian population, but in Western population who are fair-skinned, you can make it out very easily. Okay, what is it?
Butterfly rash.
It is not exactly a butterfly rash. If you see, there is sparing of the bridge of the nose there. Okay, it is just involvement of the malar area. What we can see here, it's a mitral facies. Okay, so there is sparing of the bridge of the nose in this. So it is not a necessarily butterfly rash. Okay. So fine. So this is how you will see a lot of things. Other things what you have to look for is pedal edema. Patients who are bedbound, you look for sacral edema. Okay, and you come down to vitals. All right. So in cardiovascular system examination, the most important thing is your pulse, your blood pressures, okay, and your JVP. Okay, these are the 3 most important things. So we will come to the pulse. Generally, when we say first thing what we palpate is a radial. Okay, usually with 3 fingers method, you palpate. Sorry. So with 3 fingers, you will palpate your radial pulse. All right. You look for what is the rate, what is the rhythm, okay, what is the character. Okay, character is usually seen in larger pulses such as either brachial or carotid artery or femoral artery. All right. Then there's radio-radial delay and radio-femoral delay. Okay. So first thing is the volume. So the volume of the pulse is basically contributed by a pulse pressure. That is the difference between the systolic and the diastolic blood pressures. So either it could be a low volume pulse or a normal volume or a high volume pulse. Whenever there is a high volume pulse, you have to check for what is called as a collapsing pulse. Okay. So why you have to look for collapsing pulse is again because there are certain causes which you have to identify based on your cause for collapsing pulse. So can you tell me where do you get collapsing pulse and how do you examine for that? Anybody?
Aortic regurgitation.
Okay. Tell me some common physiological causes where you can get collapsing pulse. See, simple. Try to understand the concept. Collapsing pulse is there because the systolic pressures are high and your diastolic pressures are low. So where do you get this? Where the systolic pressures are high? One is aortic regurgitation. Yes. What are the common physiological causes where you can get collapsing pulse? Okay, any high volume states like pregnancy, thyrotoxicosis, okay, beriberi, wet beriberi, okay. These are certain, I mean, of course, pregnancy is physiological, rest of the things are pathological, and anemia, okay, you can get, these are the most common places where you get a high volume pulse, okay, and a collapsing pulse. So how do you test for a collapsing pulse? Okay. First thing is you hold the radial pulse, okay, and you place the other hand over the forearm of the patient and lift the hand up, okay. So what happens is that when the diastolic pressures are low, you will feel a thumping feeling on the left hand, whereas you feel that the volume of the pulse will suddenly disappear. This is called as a collapsing pulse. All right. Most common valvular lesion, of course, you will see in aortic regurgitation. Then other low volume pulses such as which can be seen in mitral stenosis or aortic stenosis. Okay, anacrotic pulse, that is a slow rising pulse, what you see in aortic stenosis. Okay, and pulses bispherians, where you see a combination of both aortic stenosis and aortic regurgitation. So I will not go into the causes as in detail, but I will tell you how to put the pictures together so that you get into a final conclusion. Say, for example, a patient has come to me with complaints of giddiness since past 2 months, okay, and he gets on and off chest pain when he climbs 2 to 3, fleet of stairs. Okay, so basically he is having features kind of an LVOT obstruction kind of a feature. Okay, so I'm thinking probably it is aortic stenosis, or sometimes it could be aortic regurgitation also. All right. So then what do you want to look for in case of general physical examination and your vitals, that is pulse, blood pressure, and JVP will come later. So pulse, blood pressures, what all you want to look for? Anybody can unmute themselves and please tell me. Okay.
If it's a case of aortic regurgitation, we have to look for head to toe signs, that is
okay, so let's not go into the details of that because you will be knowing all this Masset sign, Rosenbach's, all those things. So, okay, one is peripheral signs of aortic regurgitation. Agreed, but peripheral signs of aortic regurgitation are not very evident in mild to moderate cases of aortic regurgitation. They are there only in chronic severe aortic regurgitations, and that too these signs are very less common. Okay, what else? What else you want to look for? But good thing.
To look for murmurs.
No, we'll come to that later. I'm just asking in GP and pulse and blood pressure. What do you want to look for?
Dancing carotids.
Okay, dancing. That all comes in peripheral signs of aortic regurgitation. Anything else specific?
Pulses, bispherians.
Pulses bispherians if there is an associated aortic stenosis. Okay, then what is the character of the pulse you will get? Okay, dancing carotids is something, yeah, dancing carotid is something what you see in the inspection, right? When you palpate the pulse, what is the character of the pulse?
Anacrotic pulse.
Anacrotic pulse is seen in aortic stenosis, okay. Whereas in regurgitation, you will get a water hammer pulse or the collapsing pulse, okay. What will be the blood pressures? What will be the blood pressure in aortic stenosis? What will be the blood pressure like in aortic regurgitation?
Low volume pulse in aortic stenosis,
okay. So low volume pulse, but what will be the blood pressures? What will be the systolic? What will be the diastolic?
It would be decreased. Systolic and diastolic both will be decreased. So,
diastolic
the pulse
will be
pressure
high.
Would be less than.
Correct. So in aortic stenosis, you have a low pulse pressure. So your systolic pressures is either normal or low, and your diastolic pressures are slightly high or normal. So what happens? The pulse pressure is narrow. So this is what happens in aortic stenosis. Whereas in aortic regurgitation, what happens? Your systolic pressures are very high, whereas your diastolic pressures are very low. So you get a very wide pulse pressure. So this is what you will see in aortic stenosis, aortic regurgitation in your pulse and your blood pressures. Okay. Then coming to other valvular lesions like mitral stenosis, mitral regurgitation. So what do you expect? What is the pulse and what is the blood pressure, and any particular general physical examination findings you want to look for? Okay, somebody unmute.
So MS also has same low volume pulse.
Right,
then
good. It could
in
be
JVP,
normal to low. Yeah. JVP will come later.
In JVP,
okay.
the
BP, blood pressures.
Okay, sir. It's also decreased, sir.
Again, the systolic will be low and the diastolic will be normal to high. So again, your pulse pressure will be narrow, and that's why you get a low volume pulse in mitral stenosis. Okay. So this is how you try to fit in each physical examination findings, and any particular general physical examination findings in particular valvular lesions other than aortic regurgitation and peripheral signs. What do you see in mitral stenosis? What you can see in mitral stenosis? Mitral phases. Okay.
Mid-diastolic murmur.
Mid-diastolic murmur. So murmurs and all will come later. Any particular things in GP and pulse and blood pressures where you can differentiate? Okay, this is this, this is that. Say for example, I'll give you a scenario. Patient is having both aortic stenosis and aortic regurgitation. So the examiner will ask you, which is the dominant lesion, doctor? Whether it is aortic stenosis or aortic regurgitation. Based on pulse and blood pressure, how do you say? Okay, anybody? Mute or chat box?
Low volume pulse means it is predominantly aortic stenosis.
Correct. So if it's a high volume collapsing pulse, it is probably predominantly aortic regurgitation. So this is how you see, pulse and blood pressure and try to correlate things. Okay. Now we will come to the JVP, the most important part in cardiovascular system. It can come as a short case, examine general physical examination of this patient. They might keep a patient with tricuspid regurgitation and they might ask you to the core about JVP. Okay. Different waves of JVP. How do you examine JVP? Why do you see at 45 degree, etc., etc. So I'll do one thing. If you have any specific questions about JVP, I will take those questions, and after that, I'll try to explain. So any specific questions you have regarding JVP, because I'm sure that you will know what is A wave, why it is C wave, V wave, etc., etc. So any particular questions you have regarding JVP? So I can answer that, and meanwhile, I'll try to explain. Okay, why 45 degrees? Now, for that, okay, consider this as JVP. Okay, so this is the blood column. All right. Now the normal JVP is less than 8 centimeters of water, and I think you should know why it is, because if you consider this as the clavicle, okay, your right atrium is sitting somewhere here. Okay, so this is the 5 centimeters distance, and whatever up and above you have is around 4 centimeters. So at total is around 8 centimeters of water. Okay, so now if I examine the JVP in this position, okay, and say the JVP is here, okay, it's a clear-cut indication that the JVP is raised. All right. Now, if I make the patient supine, okay, so what will happen? See, in a venous column, always remember there is no air. Okay, in this bottle there is air, but in a venous column there is no air. So what happens? This is collapsed. So you will see the waveform throughout, and as you see, there is a mastoid. Behind the mastoid, the JVP will disappear. Okay, behind the mastoid, the JVP will disappear. So what happens? You see a complete column of waveform in the vein, and you're not able to say whether the JVP is raised or no. So I'll keep in sitting position. In sitting position, if I examine the JVP again, in sitting position, if I examine the JVP again, if the JVP is elevated, you can clearly make it. But if the JVP is not elevated, you might still not be able to see the waveforms. So if I put the patient in 45 degrees, okay, so what happens? The edge or the highest point of the column, you can clearly make out and you can see the waveforms. If the JVP is raised when patient is sitting, there is no need to examine the JVP in 45 degrees, simply because if the JVP is raised when the patient is sitting, that means the JVP is clearly raised. Okay. So the ideal position is 45 degrees, because the highest point of the venous column, it can be clearly seen and the waveform can be clearly identified. Okay. So that's the reason why we do JVP examination at 45 degrees. Okay. Regarding JVP waveforms, see, basically you have to remember just two waves in JVP. One is the A wave, okay, and the V wave, okay. Don't bother about your C wave, because C wave is significant only in tricuspid regurgitation. So I'll just share one picture so that I can explain JVP much better. Okay, is everyone able to see this?
Yes, sir, it's visible.
Okay. See, first thing you have to worry about JVP is only two things. One is the A wave, the other one is the V wave. Okay. A is happening because of the atrial contraction. Okay. And V is happening because there is filling happening, and that's why the venous pressure is increasing. All right. So this is what is a carotid pulse. Okay. So whenever you're seeing JVP, try to either auscultate and synchronize with the heart sounds, or you palpate for the opposite carotids and then you synchronize the JVP. All right. So usually clinically you will not be able to see the C wave. Okay, so don't worry about that. Just worry about A wave and V wave. Now in JVP, which is the most prominent wave, whether it is A wave or C wave, that you should know. Anybody can unmute and say what is the most prominent wave, whether it is A wave or B wave.
A wave.
A wave, correct. So you see the carotid pulse, palpate. How do you palpate the carotid pulse? Anybody?
One at a time and against the
Correct.
transverse process of C6 vertebra.
Correct. But which finger? Where exactly?
With the thumb. With the thumb,
With the
and
thumb, correct.
the left hand should be on the head of the patient, and with the other hand you should palpate the carotid.
Correct. So the right carotid will be palpated with your left thumb like this, and the left carotid will be palpated by your right thumb. So what you do is you put the patient on, turn the neck to the left side and put the the right thumb on the left carotids and watch for the JVP. Now, whatever the waveform which comes before the carotid is your A wave, okay, and whatever comes after the carotid pulse is your V wave, okay. So normally A wave should be more prominent when compared to V wave. Okay, if it is the other way around, say for example the V wave is more prominent than the A wave, then you have to consider that there is something abnormal happening. Okay, now it is very difficult to appreciate your C wave clinically. Okay, but yes, there are ways to do it. But bedside, what you have to know for an undergraduate is how to identify an A wave, how to identify a V wave. Simple. One that comes before the carotid is A, one that comes after the carotid is V. Okay. If you want to correlate with your heart sounds, again, whatever comes before S1 is A wave, whatever comes after S2 is V wave. But the problem with the heart sounds is that to identify S1, S2, you have to palpate the carotid and synchronize, and after that you have to observe with the JVP. So which is a difficult task. So the best thing is look at the carotid, palpate the carotids, look at the JVP. Whatever comes before the carotid is A, whatever comes after is V. And normally A wave should be prominent than V wave. So this much you have to be very clear in identifying JVP. Okay. And after that, you have to identify which wave is prominent and why it is so. And depending upon your clinical scenario, you have to correlate the JVP findings. Say for example, JVP interpretation cannot happen at this stage. So you will go back, you go to the auscultation, you finish your auscultation, you see your cardiac findings, and then come back and correlate your JVP findings, and that is when you will get the proper picture of the JVP. Okay, any doubts there? I'll come back to the JVP again after the auscultation findings. So how do you identify all those things? So as of now, anything particular in JVP you want to know? Anything in the chat box? I'm waiting. Okay. So how to identify these waveforms, I've told you. Okay, just identify the A wave and the V wave. And what is the significance of this? We will go to the auscultation, palpation, and then come back and interpret the JVP again. Okay, so I'll just share a small video. I'm not sure if it'll load, but I'll give a try. Okay, is this video visible?
Yes, sir, it's visible.
Okay, so what you're seeing, the most prominent vein is your EJV, that is the external jugular vein. Okay, but if you see just below the lobule of the ear, there is some pulsations going on, and definitely it is not a single carotid obstruct. It is multiple. To do basically. Okay. Okay, so what he is trying to do is trying to occlude the the waveforms with his left thumb. Okay, and he wants to see whether the waveform is disappearing. And if you see just below the lobule of the ear, if you see there is no waveforms now. Okay, and he releases that and the waveforms reappear. So this is how you differentiate between a carotid waveform and a venous waveform. Okay, so it is difficult to say which one is A wave and C wave here, because of course we cannot palpate the carotid. What I want to you people to take from this video is that this is how you differentiate between a carotid pulse and a venous pulsations. Okay, so it is definitely obliterable. When he, with the thumb, he was able to obliterate those pulsations. So this is how you identify between a carotid and a jugular venous pulse. Okay, so any doubts so far? Audio is not required because anyhow, I'm explaining you what is happening there. Okay. How to differentiate between a prominent A wave and a giant A wave? Okay. This is something which you have to see multiple JVPs and then you will understand what is a prominent A wave. There is no cutoff to say, if this is larger than this, it is a prominent A wave. But the normal JVP, what you see, okay, in case of a fluid overload, say, for example, you see a patient with CKD with fluid overload or some amount of, okay, CKD with fluid overload is a very good example. So you see there's a fluid overload, the JVP is raised. You see the A wave and the C wave, okay, so the A wave and the V wave there. And you have a visual memory of that. And then you see a patient with tricuspid stenosis, and then you see the A wave, that is a giant A wave. Now, it is very difficult to say how to differentiate between a prominent A wave and a giant A wave. That is something which you have to see multiple patients, and then you will come to know, okay, if there is a pathological. And again, of course, you will go see the palpation and your auscultation, and then come back and correlate your JVP findings. That is how you will identify, okay? So just by seeing the JVP, can I differentiate a prominent A wave and a giant A wave? It is not possible, okay? How to tell A wave is absent? If you don't see any waveforms before the carotid pulse, that means the A wave is absent, okay? All right, so we'll go further. Okay, one is the hepatojugular reflex, which is very important. How do you do hepatojugular reflex? Anybody can unmute and tell me. Okay, hepatojugular reflex, anybody? Okay, Aishwarya, anybody?
First, we have to give a compression in the periumbilical area for at least 30 seconds, and then it's a normal individual, the JVP will be raised by less than 3 centimeter, or else I guess.
Okay, see, hepatojugular reflex is what I would say is the early sign of a decompensation of the right side of the heart. Now, what do I mean by decompensation is when I take a deep breath, the venous return increases, but the right ventricle is good enough to take that excess amount of volume. All right. So when I try to give abdominal pressure, the venous return will increase. So normally what happens, there is an increase in the JVP for up to 3 centimeters, and then it gradually comes down within 10 seconds, okay, in normal individuals. So when you press the abdomen and you continue to sustain the pressure and you don't release it, you hold the pressure for at least 10 seconds. All right, the JVP will raise and the JVP will persist to be raised for at least 10 seconds. Okay, so that is when you tell the hepatojugular reflex is positive. That means to say it's an early sign of a decompensating right heart. Okay, so that's all it means. It can happen in multiple situations. For example, pulmonary stenosis, tricuspid stenosis, or there may be a congenital heart disease where the right heart is dilated and going for a failure. So these are our early signs of a failing right heart. That's all it means, the hepatojugular reflex. And always in cardiology, remember the two things you have to remember: 10 seconds, 20 seconds. These two, 10 and 20, these two are very important number. Why? I'll tell you. Okay, one is hepatojugular reflex, where 10 seconds pressure you hold and look for elevation of at least 3 mm and more, and the elevation in JVP will persist. Okay, so this is hepatojugular reflex. Okay, any doubts in hepatojugular reflex? Okay, fine. So then, of course, postural hypotension is one thing which you have to see in certain cardiac patients, because these patients who come with syncope with valvular heart disease, you have to check for postural drop in blood pressure. So how do you check for postural blood pressure drop? Anybody? Okay, unmute please. Anyone? Okay, anybody wants to answer? No? See, even if it's wrong, it's okay. I'm not seeing your face, so you need not worry. measure in supine standing at what time interval?
So if there's a systolic drop of greater than 20 millimeters after standing for 3 minutes, then it can be labeled as postural hypertension.
Correct. So basically, how do you check? There are different methods. One is you ask the patient to lie down supine. Normally, what happens? The normal physiology, if you understand, you will understand what is postural hypotension. Normally, when a patient stands, there is a fall in blood pressure. Systolic blood pressure is by around 3 to 5 millimeters of mercury. But within a span of 2 minutes, the autonomic nervous system will kick in, and then it will stabilize the blood pressures. So what happens in postural hypotension is that autonomic component is gone. So the patient is supine, blood pressures are okay, and as soon as he stands up, you measure the blood pressures at 1 minute, 3 minutes, and 5 minutes. If the blood pressure does not normalize within 2 minutes, then he is having postural hypotension. A fall in 20 millimeters of systolic or 10 mm of diastolic indicates there is a postural hypotension. So again, the 10-20 number is important. So after this, you have to look for what is called as a pulse deficit also when you see for a pulse. All right. So how do you look for pulse deficit? Yes, the ideal method would be 2 people, one auscultating the heart for 1 minute, one palpating the pulse for 1 minute, and then you see the deficit. Suppose if there is a single person, as usually it happens in the examination, you auscultate yourself and you palpate yourself. You don't count each beat. You just count those heartbeats which doesn't come along with the pulse. So these are missed beats. So if the pulse deficit is more, probably you're dealing with an irregular heart rate, probably AF, all right? Or if it is less than 10, probably you're dealing with some form of an ectopics, okay? So this is about pulse. One is the rate, the other one is the rhythm, okay? Then you look for different characters as we discussed, okay? Then you look for the condition of the vessel wall, particularly in elderly where there is a lot of arteriosclerosis and stiffness of vessels. And then you will see blood pressures, postural drop in blood pressures. Okay. And then you will go for further things for core cardiac examination. This JVP part, again, we will come back after we look at the palpation and auscultation of the heart. Any doubts so far? Any particular questions you want to ask till here? Okay. Now, if anybody is having a question, should we see radio-radial delay and radiofemoral delay in all patients? Now, that depends. If you mention in your examination there is nothing wrong, but there is no radio-radial or radiofemoral delay. But few examiners might ask you, where do you see, why did you ask that, all those things. So it depends. But if you're asking, it's good enough. Or I mean, if you're examining for radio-radial and radiofemoral delay and looking for other peripheral pulses also, that's a good thing to do in your examination. Okay. So anything else which you want to know till general physical examination? Okay. Now the cardiac examination will start. So it is sort of interesting. I'll try to make it as interesting as possible.
I have doubts, Dr. Varun.
Yeah, Kishan. Yeah.
Others. No. From the Dr. Varun. Blood pressures. How should they check for blood pressure in lower limbs? Most of the times, we simply tend to bluff the examiners by saying the lower limb blood pressures are so and so. And invariably, examiners ask them from where did you find the cuff, BP cuff for lower limbs? Then we look up and down. We don't get the actually suitable cuffs. So how can we manage that?
Okay, so ideally what the blood pressure cuff, what we use for checking the arm blood pressures can be used to check for the dorsal pedis or the posterior tibial. So what we generally do is we tie the cuff at the calf, and then using the Doppler we measure the blood pressures. But these cuffs cannot be used for tying at the thigh and measuring the popliteal artery pressures. Okay, so if the patient is, obese, ideally the thing is the bladder width, what we use for measuring the blood pressure, should be at least 2/3 of the circumference of the limb what you are measuring. Now, generally, these bladder sizes are small for the thigh and for measuring popliteal artery pressures. So, what you can tell safely is that, sir, I tied the cuff at the calf and I measured the systolic pressures by palpatory method. It was this much. So, this is something which we can still do. Okay, but Of course, I don't see examiners going to such core that you have not examined, I'm sure. But possible. But what the cuff, what we use for the arm circumference can be used at the calf, and by palpatory method, by looking at the dorsalis or the posterior tibial, you can tell a palpatory systolic blood pressures by using the same cuff. But tying the same cuff at the thigh and measuring the popliteal artery pressures is difficult, and few examiners, if they are very particular, they might catch you for this. Okay. Kishan, is that okay? Hello?
Yeah, it's clear.
Yeah, fine. So any other doubts you have?
Let's proceed, please.
Yeah, fine. So we'll go to the cardiovascular system, proper examination, all right? The inspection, palpation, and auscultation, all right? So in the inspection, what you look for is mainly abnormal pulsations, okay? Any scars, okay? Abnormal pulsations, where all to look for, okay? One is your left infraclavicular area. The cause is usually patent ductus arteriosus, or sometimes ASD can have left infraclavicular abnormal pulsations, all right? Your supraclavicular or suprasternal pulsations, where can be seen in aortic aneurysms, okay? And then you have left second intercostal space, that is the pulmonary area, where you get pulmonary hypertension. Their visible pulsations can be there. And of course, the apical pulsations, okay? And epigastric pulsations, where there is RVH or an abdominal aortic aneurysms, where you can get an epigastric pulsations, all right? So, and look for scars, pacemaker scars basically, or any CABG scars you look for, all right? Other abnormal pulsations, very less common in coarctation of aorta, sometimes at the angle of the scapula in the posterior aspect, you look for these abnormal pulsations, all right? Other than that, any chest deformities, any movement, apex beat, whether it is displaced or not, but in inspection it might be difficult to see. But if it is visible, that is always good to comment that apex beat is seen so and so. The mediastinum, the trachea appears to be central, all right? So you are telling that the mediastinum is fine, all right? There is no chest form deformity, scars, and abnormal visible pulsations, and then you can go ahead with the palpation. So for the palpation, the first thing you want to look for is the mediastinal position, okay? Whether it is levocardia, dextrocardia, or trachea, whether it is shifted, or if there is any lung pathology causing mediastinal shift. So we have to basically focus on the mediastinum first. So we have to see two things. One is the apex beat, the other one is the position of the trachea, okay? So how do you look for the apex beat? Okay, I've done something here, all right? Is this visible?
Yes, sir.
I'll explain what it is, but is it grossly visible? Okay, fine. So basically this yellow bead, what you're seeing is the sternum. It's an imaginary thing. This is your pulmonary area. This is your aortic area, okay? This is the neo-aortic area. This is the tricuspid area, and this one is the apical area, okay? So I've already palpated and I've marked them, okay? So basically, how do you look for apex beat is you place the hand, localize the apex beat with one finger, okay? If you're not able to feel the apex beat, turn the patient into left lateral position, palpate, and then localize your apex beat. Normally, the apex beat is half an inch medial to the mid-clavicular line in the left fifth intercostal space. But when you try to locate by turning the patient to the lateral position, there might be a displacement of half an inch. That is 1 to 1.5 centimeter displacement of apex can happen when the patient is shifted to lateral side. So make sure when you're measuring the apex beat, you put back the patient to supine position and localize the apex. Then you look for the tracheal position. So you say if everything is fine, then probably yes, the mediastinum is in place, okay? So again, there are two types of apex beats. One is normal, or it could be a LV type of apex or an RV type of apex. So how do you tell whether it's an LV apex or an RV apex? Anybody can unmute and say? Anyone?
So LV apex may be shifted down and out.
Correct.
And RV will be rotated and be shifted laterally.
Correct. So that rotation we will not be able to make out. So it will be out as in the fifth intercostal space, outside the midclavicular or on the midclavicular line. Okay, fine. So now what abnormal pulsation you can get in an RV apex? What abnormal pulsation you can get in an LV apex? Okay, anybody? RV apex? See, simple. Yes, very good. Parasternal heave is an abnormal pulsation. What else? What else? What else? We discussed so many abnormal pulsations, right? Just now. So what else you can get?
So tapping apex hyperdynamic.
See, no. Tapping apex is something which is very particular for mitral stenosis. Okay. Yes, heaving apex, yes, it indicates that there is a probably eccentric left ventricular hypertrophy. So you can get an LV type of an apex. Very good. So if you're telling something like, say, mitral regurgitation or aortic regurgitation where there is dilated LV, yes, I will take that answer. So there is abnormal pulsation. That means apex is shifted out. LV apex is there, and you can have a hyperdynamic apex. Okay, but what abnormal pulsations you can expect in them? If somebody told pulmonary pulsations, yes, in RV apex you can get a abnormal left second space pulmonary pulsations. All right. What else? Where do you get epigastric pulsations? RV apex or LV apex?
RV apex.
Correct, RV apex. So you can find an epigastric pulsation in RV apex. So any abnormal pulsation, what you can get an LV apex? Come on, think. What are the lesions you can get an LV apex? One is MR. The other one is? No, I'm talking about abnormal pulsations, not about thrills. Thrills are just palpable murmurs. We'll come to that later. Abnormal pulsations. Where do you get left atrial pulsations? Abnormal left atrial pulsations. Which area? I just mentioned there. Aortic area pulsations are seen mainly in aneurysms or sometimes in certain clicks. I mean, bicuspid aortic valve or aortic coarctation of aorta. Okay. No. See, what happens when there's a mitral regurgitation, you can have an abnormal LA, left atrium can have abnormal pulsations in the left second intercostal space, almost close to the pulmonary area. So how do you differentiate between these two sometimes? Anyway, it's a postgraduate question, but anybody wants to unmute and say? Okay. Anyhow, let's forget it. So what I want you to remember is when there are abnormal pulsations, try to correlate with your apical findings, whether it's an LV apex or it's an RV apex or it's a normal apex. So if you feel it's an LV apex, so what this abnormal pulsation could be, or if you feel it's an RV apex, what this abnormal pulsation could be. All right. So we do that and we look for abnormal pulsations and parasternal heave. How do you look for parasternal heave? Is you place the ulnar border of your hand on the left parasternal area and look for the heave. Of course, you have 3 gradings which are there. And when you're palpating for your left second intercostal space, you basically palpate with your fingers, all right? Or sometimes you can place your hand like this, localize, and then you place your fingers like this. Same with the aortic area, any abnormal pulsations, you place your hand and then localize with the fingers. So this is how you look for any abnormal pulsations if there are according to the areas, okay? Any doubts so far, anything? Any particular questions so far? Okay, right. So if there is nothing, then we'll go for palpation of the thrills. So thrills are basically nothing but, your abnormal murmurs, whatever is there. If you're able to palpate them, they are thrills. Of course, you have grading of murmurs from 1 to 6 for systolic. All right. So if there is 3, that means there is 3 and more. That means the patient is having thrill. Okay. So I will not go into the different gradings and all, but of course, you will palpate the apex. Your mitral area murmurs have thrills at the mitral area, tricuspid lesions at the tricuspid, and corresponding areas with the pulmonary and your aortic areas. So if there are thrills. One area what you have to look for is again carotids. Palpate the carotids because you can have carotid thrills in aortic stenosis. All right. So these are certain thrills which you have to look for. Okay. And then you go for the percussion. Now, percussion, in cardiac cases, they might not ask, but if you want to do percussion, there are only 2 proper indications where percussion might be helpful. One is if there is a dextrocardia. The second thing is if there is a pericardial effusion. All right. So these are the 2, proper indications where, percussion is still justifiable. So how do you do percussion is, so basically, this is the apex. So you will palpate the apex. localize the apex. All right. So a space above, okay, you percuss from lateral to the medial side until you get the cardiac border and mark it. One space above, percuss from lateral to the medial border and mark the space. So this you will get your left heart border. All right. On the opposite side, first thing you look for is you look for the liver dullness. Palpate from above down, you'll get the liver dullness. Mark the liver dullness, go a space above. From lateral to medial, just percuss and then mark your right heart border. Always remember your right heart border is usually coincides with the right parasternal border. All right. So usually that will coincide. If the right heart is overshooting the right parasternal margin, then probably you have having a cardiomegaly, or sometimes the apex itself might be shifted on the opposite side where you will have a dextrocardia. All right. Okay, so if it is not palpable in obese patients, what you can do is you can percuss down from above on the left side. So you will get the lung resonance. Following the lung resonance, you will get the fundic gas. Okay, so move above a space and percuss from lateral to the medial side. Wherever you get the dullness, that will be your left heart border. But again, in obese people, you might not be able to clearly identify pericardial effusions. But yes, can be done this way. Identify the fundal gas tympanic node and then move a space above, percuss from lateral to the medial side, mark the dullness, and you will get the cardiac borders. Okay, so this is how percussion you will do. Okay, so then we'll go ahead with the auscultation. Okay, auscultation, try to follow a particular pattern. Either you do the apex, tricuspid, aortic, pulmonary, and the neo-aortic, or whatever pattern is possible. But try to concentrate on one particular pattern so that you don't miss anything. Then, of course, you have to auscultate for the carotid just for any audible sounds are there. Okay, bruit is there. And of course, sometimes aortic aneurysm. Say, for example, epigastric pulsation is there. How do you look for epigastric pulsation? Is again at the lower end of the sternum, you place the thumb. Okay, if the pulsation is expansile and if it is hitting the pulp of your finger, that means it is the abdominal aortic aneurysm. If it is hitting the tip, then probably we are dealing with the RV. Okay, so you follow a particular pattern. Auscultation, you might have to auscultate for abdominal aorta also, and you have to look for the carotid thrill, carotid bruit also. Okay, so now regarding writing your findings in particular areas, all right, always remember your mitral area, tricuspid area is examined in supine position. Your aortic and pulmonary area and the neo-aortic area is best auscultated in sitting and leaning forward. All right, so mitral area, the most two findings is either you get a regurgitant lesion or a stenotic lesion. Okay, and you might get a loud S1. Okay, say for example you have a mitral stenosis, what you expect is a loud S1. So you will have a tapping apical impulse, okay, which is well localized, and there is no displacement of the apex. It is at the left fifth intercostal space medial to the mid clavicular line. Okay, so then you auscultate, you will hear a loud S1. All right, and you put the patient in the left lateral position, auscultate with a bell, you will hear for a soft rumbling murmur, which is mid diastolic. So you put together, you get a soft rumbling murmur in the left lateral position with the bell and a tapping apical impulse and a loud S1. So all these things point towards mitral stenosis. Always remember, mitral stenosis murmur is always localized. So when you talk about the murmur, where exactly is the murmur? Location. What is the intensity of the murmur? Is it localized or radiating? Whether it is systolic or diastolic, and any dynamic maneuvers which can increase the murmur. Say, for example, for mitral stenosis, if you do exercise such as squatting, okay, or sit-ups, that can increase the cardiac output, and hence your mitral stenosis murmur will increase. If there is a mitral regurgitation, contrarily, you will have either anterior leaflet is involved or posterior leaflet is involved. If anterior leaflet, you have radiation of murmur towards the axilla. If posterior leaflet is involved, then you have radiation of murmur along the left parasternal edge. Okay, and of course it will be a systolic murmur, whereas diastolic murmur in case of mitral stenosis. Okay, how do you differentiate between systolic murmur and diastolic? Of course, you will be palpating your carotids meantime, and then that is how you will identify it. Then coming to your tricuspid area, the most common murmur you hear in tricuspid area in exams is tricuspid regurgitation. Okay, it is a murmur which radiates along the left parasternal, which increases on inspiration. So for these dynamic maneuvers, what you can do is you can do a leg raise and auscultate at the tricuspid area. If it is tricuspid regurgitation murmur, obviously the murmur will increase with leg raise. Okay. Then you come to the aortic area. Aortic area, again, it could be a systolic murmur or a diastolic murmur. So systolic murmur is radiating along the carotids. So probably it is aortic stenosis, ejection systolic murmur, or it could be a diastolic early decrescendo murmur. Early decrescendo murmurs usually radiate along the right parasternal area, whereas systolic murmur, that is aortic stenosis, will radiate along the carotids. Coming to the tricuspid area, one thing you have to mention is your split is very important in your, sorry, not tricuspid area, pulmonary area. The split is very important. So you get a systolic murmur, same as ejection systolic murmur in aortic area, or the diastolic murmurs are extremely rare in undergraduate exams in pulmonary area. But only thing what they expect you to do, tell is the splitting. How is the split? S1, S2 split. Okay. So if there are any particular murmurs, you will tell about radiation in intensity and aggravating or the dynamic auscultation you will do and let them know. And you auscultate for, of course, carotids and the aorta if it is palpable, or if you're getting any abnormal epigastric impulses. So now we will come to individual cardiac lesions and see how the JVP will react or respond, or how it will be. Say, for example, in case of mitral stenosis, okay, patient is having severe mitral stenosis. All right. So what do you expect in JVP? Anybody who can tell me? So I presume I'll tell you one thing. In cardiovascular system, if you read everything and if you're able to interpret the JVP or explain the JVP findings in particular valvular lesions, then probably you're understood cardiology to the best. Okay. Anybody can unmute and talk. There's no problem. I think there's hardly 40 people are there, so you can unmute yourself and talk. Okay. In case JVP has V wave functional TR, yes, possible. Yes, there is a CV wave, what we call. So there is a CV wave in tricuspid regurgitation. Very good. Then what else? Okay, in mitral stenosis, there can be atrial fibrillation. So when there is atrial fibrillation, the A wave can be absent. All right. So what else? What are the other findings that can be there? Okay, anybody can unmute and answer? Any other findings you can see in JVP in mitral stenosis? Prominent A wave, good. There is simple. See, try to understand what happens in mitral stenosis is there is initially the pulmonary artery hypertension happens. So once there is pulmonary artery hypertension happening, the A wave will become prominent first. All right. And after that, if the patient is developing AF, etc., the A wave will become absent. And then if the pulmonary hypertension is worsening and there is a functional tricuspid regurgitation develops, then you get a CV wave. All right. So the V wave and the Y descent will become very prominent. So this is a JVP finding which happens in mitral stenosis. What happens in mitral regurgitation? Okay, so mitral regurgitation, it might not be very relevant. So we will go to the tricuspid regurgitation. Again, you will get the same CV wave, what you expect when there is a functional tricuspid regurgitation. All right. So any other doubts you have in particular auscultation and JVP findings before we go on further? Okay, fine. So if there's any aortic valvular lesions, aortic stenosis or aortic regurgitation, the first chamber to be involved is the LV and then the LA. So the same changes what you get in mitral stenosis will appear, but it will appear much late, and usually the left heart failures features, that is orthopnea, PND, okay, and exertional breathlessness comes first, then followed by your JVP findings. All right. Whereas in case of mitral disease, usually the JVP findings are much earlier when compared to that of aortic valvular lesions. Right side, of course, tricuspid regurgitation, the most common valvular lesion you will get in the exams. Okay, so that will have a prominent CV wave. All right, and tricuspid stenosis, again, you will get a prominent A wave in the JVP, and you will not see any CV wave. Okay, and your Y descent will be very slow in case of a tricuspid stenosis. Whereas it will be normal in case of, or it can be exaggerated in case of a tricuspid regurgitation. All right. So this is the JVP findings, how you will correlate with your clinical examination, your pulse, blood pressures, your auscultation examination, your murmur findings, and then correlate with the JVP and what you expect in JVP. So if you have understood this much, I think I'll try to put some case scenarios, and let me see if anybody wants to take this and answer. Anybody voluntarily wants to answer these case scenarios? Anybody?
We can start, Dr. Varun. Depending on the case scenario, they will answer if they don't.
All right, fine. So any doubts you have, anybody so far?
Yeah, I have in general one doubt, especially coming to the cardiovascular system. I would, as a suggestion also, I want your opinion as well. We have this tendency in the usually for you undergraduates in the examination, we go to the patient and keep on like whatever we ask the question, and as soon as they answer, we tend to write the same in our answer, whatever case sheets, like in the same proforma. Is it wise to do that in case of especially RS and CVS system, or instead you go through the entire history and examination and then come back, sit back, and think the exact case about the case and write everything at once? What do you suggest?
I think
because why I'm telling it so happened with my friends in the examination. They started as a respiratory. The symptoms were most likely like respiratory, and they started in examination and they started writing simultaneously. And at the end, in the auscultation, they found a murmur. Okay, and they retrospectively asked, "Do you have any other symptoms?" They like on questioning repeatedly. Then they came out with some other symptoms. Patient. Then the entire case has to be changed. Okay, then it turned out to be the entirely different case altogether, a serious case. So they didn't had any time to rewrite it, or they didn't had extra papers also. So I think it's wise to what you say, Dr. Varun?
Okay. See, when you enter the case, you know which system it is. All right. One is, say, if it is a cardiovascular system, you probably know before entering that particular station that it is a cardiovascular case. Now, if the patient says, I have generalized weakness, I have fatigue, okay, so you cannot, we straight away say that, yes, it is LV features, I mean, left heart failure features, because it is vague and it can involve anything. So what I always suggest is take the chief complaint, go briefly about it, ask for the cardinal symptoms of that particular system. And then you can always, do the general physical examination first, and then do a brief cardiac examination. You see what particular valve is involved, come back to the history and probably take further history according to that, and then fine tune it. Because most of the cardiac cases will, if you see mitral stenosis, they will just be sitting there. They will tell, I have breathing difficulty. That's all they will tell. So you might ask about cardiac history, you might ask about respiratory history, and a lot of past history, which might not be relevant at all in this case. So what I suggest is you can do a brief general physical examination and systemic examination, come back and then probably fill up all the negative things, what is particularly relevant. That is a better thing to do. But of course, in MBBS exams, I feel most of them will be knowing the cases already. So don't go with that mindset. The moment you go with that mindset,
that's also dangerous. Actually,
it's very dangerous.
That's also most of the times RPGs will tell us, oh, this is the case and these are the murmurs are there. Correct. Everything they will tell us, and they will, like you mentioned in the beginning itself, we will go with that prefixed mindset.
Correct.
Yeah, this is going to be mitral stenosis case, and I'll be doing that.
Correct.
And it so happened there are some small extra findings where like maybe anemia, one extra murmur was there, hemic murmur, something which were missed.
Correct.
Because thinking that we are focused only on mitral stenosis.
Exactly.
Examiner
so this
picked up
exactly.
that. Examiner picked up that and asked, "Can you appreciate any other murmurs?" The student was very adamant, "No, sir. Only these two murmurs are there." Like he was literally failed. Okay, for like. So we should not be so like. We can at least say, "Sir, can I try again? I couldn't appreciate, sir." That's a better or polite way of answering, maybe. Instead, or please never go with such prefixed mindset for any case. Okay. Go like in a very holistic, open mind, be flexible and be open-minded before approaching any cases. Okay, it can be it can be anything at the end of the history and examination. Okay, even the PG might have missed some findings and maybe with the diagnosis as well. So like Dr. Varun mentioned, please go with a very open-minded and be flexible with your approach and the findings.
Correct.
Yeah. Please proceed.
So, okay. So we'll come to case number 1. So let's see how you will interpret these cardiac findings. Okay. This is a 60-year-old person who is a known hypertensive, came to us with sudden onset of breathlessness, all right, which was acute in onset, probably within hours. All right. There was no history of chest pain, no history of, there was history of orthopnea, there was history of palpitations. Palpitations on digging deep, he says it was sudden in onset, irregular, and he feels like a something irregular beating in his heart. All right. So then we examined him. His heart rate was around, his pulse rate was around 140. He had irregular pulse, all right, variable volumes. So we did look for the pulse deficit. The pulse deficit was around 16. So we did measure the blood pressures, which was little difficult in this irregular pulse rate, but it was around 130/80. We did the systemic cardiovascular system examination. We saw that in the inspection, the apex was an LV apex. All right. He had bilateral basal crepitations. JVP, we saw JVP, there was absent A waves. All right. And the V wave was normal. Then we looked into the other cardiac auscultations. There was a pansystolic murmur in the mitral area, which was radiating towards the left axilla. All right. So can somebody put all these findings into one place and tell me what all could be the possibilities in this patient?
You have told everything except for one word answer. You explained
Correct.
so well.
No, but what I'm trying to say is this cardiology is so beautiful.
Beautiful.
You
It's like
go
mathematics.
on, correct. You go on putting the pieces together. You will just enjoy it. Correct.
Yeah.
Acute MR. So AF is there. Very good. Why do you say acute MR? There was no history of chest pain. Okay. Mitral regurgitation is there with AF. Very good. What else? What else? See, what are the possibilities? I'll tell you. One, probably patient had a mitral regurgitation before, and now he has developed an AF that has worsened his symptoms, and that's why he has come in a decompensated state. One possibility. Second possibility, either it could be an MI and he has developed an acute MR, but of course, all your acute MRs post MI will develop around 3rd to 5th day, not very early within few hours. Okay, so that is something which is ruled out. The third possibility is probably is a known case of ischemic heart disease. He's having a functional mitral regurgitation, and now AF has caused his worsening of symptoms. So these are the three possibilities which you have to consider when you see these findings in a patient. So again, the history, you will come back and see if he's had any cardiac event before, any MI was there, any stenting was done, okay, or he had any exertional breathlessness before, any nocturnal enuresis, okay. This will help probably if he had any heart failure symptoms before, and now because of the AF, he has decompensated, and the MR is just a functional MR. So how do you see? If the MR murmur is having some thrill, then probably we are dealing with an organic MR. Or if the MR murmur is not having any thrill, and it is of grade 1, 2, then probably we are dealing with a functional MR. So what we have to look for is an apex speed. Look at the apex speed. If it is out, LV apex kind of a thing where it is out, and if the apex is hyperdynamic, probably we are dealing with a organic MR. All right. But if you see the LV is weak, or I would say there is a palpable S3, or if the apex is not hyperdynamic, then probably we are dealing with a ischemic heart disease with a hypokinetic LV and now a functional MR and then AF. So this is how you put these pieces together. So I'll come back to another case. Okay, let's see how you will interpret this. I'll give you the diagnosis this time. So you tell me what are the findings you can expect in a cardiology examination. All right. This patient is a 40-year-old male with a previous history of some cardiac disease. We don't know what it was, but we did an echo. Echo was showing a VST was there with right ventricular hypertrophy and this thing. He was almost in a decompensated state. RV failure was there. So what are the findings you can expect in a VST with RV failure and Eisenmengerization in his last examination? What are the findings you can see? VST is there with an Eisenmengerization, and there is a right heart failure. Okay, so can anybody take up this question for us? Okay, I want somebody to unmute and answer. See, go in a stepwise manner. What do you see in the pulse, blood pressure? What do you see in the JVP and cardiac findings?
I request Rishab. Request Rishab to unmute and try to answer this one. Rishab, are you there?
Yes, sir.
Yeah, Rishab, try to answer this. Come on.
So there'll be cyanosis.
Okay, very good. In the general physical examination, there'll be cyanosis. Excellent. Then
why? For the benefit of all the members, tell why there is cyanosis.
So because there's a mixing of oxygenated blood with deoxygenated blood, because it's reversion.
Right to left, VSD in Eisenmengerization, there is right to left flow, shunting. Okay, because of the increased right heart pressures. Okay.
Yes.
Okay.
And
Then what else?
There'll be wide pulse pressure.
Okay.
Then there'll be a continuous murmur.
Can you tell me why there is wide pulse pressure, Rishab? I mean, if you don't answer also, it's okay. But if you answer, I'll be very happy. That means
So
probably you're
because of
understanding well.
volume overload.
Excellent. Volume overload is there in VST. Excellent. Okay. Then.
And I don't know about the pulse.
Okay. No problem. It's a high volume pulse. Okay.
And, murmur would be a continuous murmur.
Okay. Before going to murmur, JVP. What do you expect in JVP?
Then the A wave would be reduced.
No, it will be prominent. It will be a prominent A wave. Because we are dealing with the right heart hypertrophy, right? Right ventricular hypertension and hypertrophy.
Yes,
so
yes.
Obviously, A wave will be prominent. Okay, then.
On inspection,
there is a if there is a functional TR, you can have again a prominent V wave also, a CV wave, prominent CV wave also can be there. Okay. All right.
So
then
on inspection,
cardiac auscultation.
There won't be any. Okay. Auscultation, there will be murmur in the.
No, inspection. You finished the inspection. I'm sorry, I jumped to auscultation. Yeah.
Okay. Inspection, there won't be any pulsations, I feel.
Right ventricular hypertrophy, Rishab.
So that will be an apex shift.
Yes, there is a shift of apex. RV type of apex is there. So the moment there is an RV apex, what you will see? Additional pulsations.
For parasternal heave.
Good. Yes.
Very good. Very good.
And epigastric pulsations.
Excellent. Excellent. Very good. And a palpable P2 probably. Okay.
Probably.
Okay. Then, so inspection, palpation done. Next, auscultation. What do you want to look for?
We look for the murmur. So here it will be a
before murmur. First step by S1, S2, then go for murmur. Go in the order only.
Okay.
So palpable P2 is there means what in auscultation?
There will be pulmonary hypertension.
Correct. So you'll have a loud
on
P2.
Auscultation, what will be there? Loud P2. Yeah.
Yes.
Yeah. Then what else? What murmur? What area? Where is it radiating?
Continuous murmur heard in the left.
Not continuous murmur. It's more or less a pansystolic murmur you'll have, not a continuous murmur. Okay.
Which can radiate to the back.
Okay. But mainly in the parasternal area it will be. Okay. It will be in the right to left parasternal area. Okay. Usually VST with reversals. And you can have a tricuspid regurgitation murmur, which is functional murmur. Okay. So this is how, you will see the moment you examine the patient. See, in cardiovascular system, there are only two ways. Either you go from up to down, that is history and physical examination, and you diagnose at the history level and examine the patient. Or if you're very good in picking up the findings in cardiovascular system, you can examine the case and come back to the history. Okay. So either way can be done. What I'm trying to say is you put the pieces together, you will enjoy cardiovascular system to the core. Okay. So that is it about cardiovascular system briefly. And writing your diagnosis, what is it? Whether it's a valvular heart disease or a non-valvular heart disease. If not non-valvular, what kind of, whether it's ischemic, non-ischemic. Okay. If it's a valvular disease, what is the valvular lesion, what you're expecting? And then what is the severity of it? Of course, different lesions have different severity clinically, how you can assess. I think mitral stenosis, aortic regurgitation, you would have read all those theories. And whether it is compensated or decompensated. When I say compensated, that means his blood pressures are fine. He doesn't have any symptoms as of now. He's asymptomatic. When I say decompensated, what is the decompensation right now? Okay, whether it's LV failure or an RV failure features, and any other complications such as infective endocarditis. So you put this, and last, of course, etiology, you will just mention what could be the probable cause. And regarding management part or the investigations, which some examiners might ask you, see in cardiology, the basic investigations are blood investigations such as CBC, of course, in infective endocarditis and all those things. ESR is important. And sometimes if you are suspecting some hemolysis, mechanical valve, endocarditis, peripheral smear might be important. ECG, yes, very important, chest X-ray. And of course, last would be the echo findings. All right. So based on this, these are just helpful in, just to wind up the exam session. All right. And further, based on the further findings in the ECG X-ray, you can ask for further investigations also, but we will stop there. Okay. And management depending on the cause. Most of the times it will be either diuretics or some digoxin or something. So there we will wind up the case. So any doubts, anything in cardiovascular system specifically? Somebody has asked, S2 be widely or narrowly split? Sanjana has asked some questions. Sir, will the S2 be widely or narrowly split? In which case?
In that VS second case she was asking, I answered her. Okay. When there is a pulmonary hypertension,
yeah, it will be one. Yes, yes. Anything? Any question?
Any other doubts? Can you please just sum up the things, please, for the benefit of all?
All right. So basically, in cardiovascular system, cardinal symptoms. All right. Now you have to see what is the combination of cardinal symptoms you will get in different symptoms. Patient coming with breathlessness, palpitations, probably you're thinking of the left ventricle. Patient is coming with swelling of the lower limbs, clubbing, cyanosis, probably you're looking at the right side of the heart. Okay. So you club these cardinal symptoms and come to some probable etiology at the level of history taking. And then you go to the general physical examination. See, general physical examination is very important in cardiovascular system. Most of the diagnosis happen at the GP level. So look for the pulse, blood pressure, pulse deficit, type of character of pulse. Okay, blood pressure. What is the pulse pressure? Look mainly for what is the pulse pressure, what is the systolic, what is the diastolic, and pulse deficits, and etc. And peripheral pulses, radial, radiofemoral delay. It is I don't see the use in undergraduate exams because we don't give such cases. So stick to basics. Okay, be strong in your basics. JVP is something which is very important. I always stress. With just the JVP, if you're very skillful in identifying the JVP, you can almost tell what cardiac lesion is there by just looking at the JVP and taking the history. So, and the questions also, the examiners are very fond about JVP. So if you're very confident in that, probably you might score a little higher. And coming to the cardiovascular system examination, there's no much in inspection, palpation, auscultation, because it is very simple. But what you have to look for is main when you're looking for the pulmonary area, aortic area. Please ask the patient to sit, lean forward, breath held at the expiration, and then do the examination. For mitral area, don't miss turning the patient to left lateral and auscultating and palpating for the apex. And of course, in tricuspid, you will be examining in supine position only. Any abnormal pulses or any cardiac findings or murmurs, try to look at what abnormal pulsations can be there in these findings and look for them in particular. Okay. So, and diagnosis, don't give a diagnosis what the case sheet says or what the echo says. Give the diagnosis what you think is right according to your clinical findings. The moment you try to commit to a diagnosis based on the case sheet and echo findings, you will be in trouble. Okay, because the moment you quote the diagnosis, you'll not be able to justify why I am quoting this diagnosis. So that is what puts most of you in trouble during exams. So, okay, so try to give a diagnosis according to your clinical findings. That is the most important thing. All right. So at least you will know what to look for in case of so particular diagnoses. So in that case, say for example, you know that the case is aortic stenosis already, try to see what all you have to look for, and then you examine those things. You cannot write a wide pulse pressure and you cannot write the diagnosis of aortic stenosis. The moment you write aortic stenosis with a wide pulse pressure, the examiner will straight away ask, what have you done? Okay, so you don't get into trouble like that. So keep it simple. I think cardiovascular system is easy enough. Okay.
Yeah. It's like mathematics. You will, if you're really if your approach is correct, you will never go wrong. Whereas this respiratory system and all is like a graveyard. If you say it is resonant, examiner say no, it's dull. There are chances like subjective variations can be there. Whereas in CVS, it's not like that. It's like mathematics. It's wonderful. And my request as a senior is to all my friends over there is, please don't try to bluff the examiner there. Okay. In undergraduate level, even we found it very difficult, especially with murmurs and all. Yeah, we already had a session by Dr. Varun about the murmurs, how to interpret, how to simplify the murmurs. You can go watch in our YouTube channel about the murmurs. Yeah, at least you should be able to tell it's a systolic murmur or diastolic murmur. You need not be telling about the early systolic murmur or mid diastolic murmur. To that extent, it's not required maybe. but at least you should be able to tell it's a systolic or a diastolic murmur. Am I right? And other, you should see the answer may be wrong, but your approach, your writing approach should be correct. Murmurs should be written in 3, 4, 5 points. Okay, all those things. It's what's the grade of the murmur, any radiation is there or not, in what area it's heard better, whether it's heard better with the diaphragm or the bell. All those things. There are some particular points in which the murmur should be explained. All those things you follow properly. Your answer may vary here and there, but if your approach is proper, if the proforma is good enough, then there is no doubt you will pass or you will do well in the exams. And yeah, again and again requesting, don't try to bluff. If the examiners ask you something, if you're not sure, please request them, sir, can I examine again, can I look at it again and tell you, or can I please, I couldn't appreciate it, sir, I'm sorry. Please be very humble or polite to admit whatever we couldn't appreciate it. Okay, and don't try to argue in the exams, or don't try to tell something which we didn't hear or we couldn't see in the examination. Anything from your side, Dr. Varun, please help them, because exams are coming up. Most of them are tensed, so please
I'll
make
tell
it
you, exams are simple. Don't panic. That is the most important thing. And most of the times you will know the diagnosis. Say, for example, there is aortic stenosis or aortic regurgitation in this patient. So what are the clinical findings? Now, you should not see the case paper and say, okay, BP is this much, pulse is this much. No, you should tell, if somebody has written a blood pressures of 120, 90 for a patient with aortic regurgitation, the moment you see that, you should say this is not right. Okay, that should be the confidence level when you go to any exam. So what I'm trying to say is, just focus on the basics. That is all. Okay, there is no requirement to tell what is the differential diagnosis of so and so. These are questions which arise when you're doing very well. Okay, so try to stick to your basics. Be strong in your basics. Most important is your GP, pulse, blood pressure is very important. JVP is to the core important in your cardiovascular system. Okay, I think somebody has asked a question: what is the easiest way to differentiate by systolic and diastolic murmurs? Okay. The best thing is, of course, palpate the carotid and see. That's the best thing to differentiate between a systolic murmur and diastolic murmur. Okay, there's no other way you can differentiate. Pericardial conditions, how the apex beat will be. Of course, the apex beat might not be very well appreciated in a constrictive pericarditis. Okay, whereas in restrictive cardiomyopathy, it can be normal. All right. So in pericardial effusion, of course, there will not be any apex beat, or if it is there, probably it will be displaced down and out. All right. So that is not, just be very confident with your basics. All right. And most of the times the examiners will be not trying to prove that they know more. They don't want to do all those things. What they're basically looking at is, how is your approach? That's it. So if you say, sir, the pulse pressure is wide and the pulse volume is more, collapsing pulse is present, I'm getting some diastolic murmur in the aortic area. I'm not sure whether it is early or mid, but looking at the other findings, I think it is probably aortic regurgitation. Finish. Okay. Nobody will, put a blame. You didn't tell whether it is early or mid. It's a decrescendo murmur. No. The moment you put all these pieces together, they say, okay, good. Your approach is fine.
And physical examination, especially this pulse, blood pressure, and that cyanosis, all those things we should be very thorough with in the undergraduate level. Okay, this pickle, what we say pickle, the pyloric stress, cyanosis, that thing, and pulse and BP maybe. Anything can be asked, and we are expected to know everything about that at least. They hardly go till the diagnosis or your systemic examination. They will catch hold of us here itself. Okay, what's the definition of stress? What is the definition of the white pulse pressure? In these small things only, basics only, they'll catch hold of. So we'll be more thorough with these basics rather than concentrating on the rare features of dilated cardiomyopathy or with some of the findings of AS or AR. We'll be more thorough with the basics like pulse, like very rightly mentioned by Dr. Varun. The JVP, the features of JVP, the waves of JVP, and the blood pressure things. All those things will be very thorough before going to examination. Okay, and all the other things are for high marks. Maybe first thing is to pass in examination. If you're thorough with the basics, no examiner can fail us. Yeah. So if no more doubts are there, we'll. How to make out the waves of JVP, that you already answered, Dr. Varun.
Correct.
So does lung sounds disturb heart sound during auscultation?
Yes, possible. Say, for example, if you're hearing some sounds like pericardial rub, or if it's a very soft diastolic murmur, sometimes you can get confused. And that's the reason why you ask for end inspiration and expiration auscultations in particular things. For example, right-sided end inspiration, left-sided end expiration. You hold the breath and auscultate if you're in doubt.
Please suggest book for CVS examination and theory.
For undergraduates, the best book I would say is McLeod's. It's one of the best book for undergraduate clinical examination. And of course, you have your Kundu and Alagappan. Alagappan, I would say, is too much. Kundu should be fair enough for your exams. I mean, if you have read it, it's good. But for exams, that should be enough.
And the reasons also, okay, for one specific thing, there will be 4, 5, 6 causes will be there. Better to know and remember important two causes for each. For clubbing, 2 cardiovascular causes, 2 respiratory causes, like that. If you, what happens if you go to remember all 10 points, and in the exam also we tend to tell in the some in a order that which
rare
is
causes.
Rare causes first, unimportant ones first. That's not the way. Know the 2 important ones first. Okay, and try to tell that one. Okay, that's the way to remember and tell the answers in examination. Yeah, almost everything covered, I think. Theory part we will read by ourselves. Only the main approach to the examination and what all to be done in the examination was in detail explained by Dr. Varun. If no more doubts are there, we'll end this session. Thank you so much for your time and inputs, Dr. Varun.
Yeah. Thank you, Kishan. Thank you.
Yeah, you are always with us, helping us, supporting our students, and guiding us. We require this in throughout, okay, in future as well. And as and when you're free, please try to take some classes for us.
Sure. Yeah.
Yeah. On behalf of all the members, I would wholeheartedly thank you for all your efforts. Yeah. Thank you so much.
Thank you, Kishan. Thank you.
Thank you so much, sir. It was indeed a comprehensive clinical class. The discussion was really very useful for all of us. Thank you so much for teaching and guiding us. We are ever grateful to you. Need your blessings, guidance, and support throughout. We also thank all our participants who were enthusiastically answering and were actively involved. Thank you so much, one and all.